Gives me great pleasure to introduce our next speaker, who is Dr. Asha Patel from Innovating Minds. Thank you, Dr. Asha Patel. Dr. Asha is coming in to speak about domestic abuse, mental health, and trauma-informed practice. So without further ado, I'll hand over to Dr. Asha.
Hi there, I'm just going to share my slides. Just let me know if you can see these okay. Can you see the slides okay?
Not yet, Dr. Patel.
No. Okay. What about now?
We're there now.
Yeah, that's come up now.
Perfect. So hi everybody. So I'm Dr. Asha Patel. I'm a clinical psychologist and founder of Innovating Minds. And just to give you a little bit of background, I used to work in forensic mental health services. So I've worked with high profile individuals that have committed serious offences such as murder, sex offences, but have also experienced significant mental health difficulties. I've worked across the spectrum, so I've worked with children, babies, young people, and what we do at Innovating Minds is enable adults and children access early trauma-informed help. And particularly we support children and families that are affected by domestic abuse. So in today's session, I will be talking about some really sensitive content, and therefore it's important to really think about your own mental health and well-being. So if at any point you do feel triggered or a little your body feels uncomfortable, do feel free to opt out, and I will hang around at the end if anybody does want to get in contact. So we're going to go into thinking about domestic abuse. And when we think about domestic abuse, there's lots of different types of abuse, whether it's coercive control, physical violence, whether it's financial abuse. So there's a whole spectrum. But what I really want you to think about is actually the impact that it has on the nervous system, and to really think about the impact on children as well. So yes, there's the impact on the adult as the adult victim of domestic abuse, but also children are now recognised as victims in their own right. And actually their experiences, everything that they live in, that environment, that fear, that treading on eggshells, the unpredictability, that stress, that tension is stored physically within the body. And it's actually the nervous system that holds on to and records all of those sensory and emotional experiences. And this information that the body holds on to is really crucial for survival and how the body and the brain respond in order to keep that individual safe. And this is all happening without even people realising. And so I want to take you through kind of thinking about the sensory experience and the impact that domestic abuse has on somebody's physical body. Typically, when we're working in these services and working with adults affected by domestic abuse, we typically go to a cognitive response. And how do people process the trauma cognitively? What do they think about it? Maybe what could they do differently next time so they don't go into another abusive relationship? But actually a crucial part of the information that we're missing is thinking about, well, actually, what impact is this having physiological on their body? And then in return, what impact does that have on the brain? So if you think about it logically, our body is larger than our brain. And therefore, what is happening is the brain is listening to the body. So it's not the other way around where we think that the brain is controlling everything and is the main point of call. So if we change how we think, that is going to change how we feel and what we do as a response, how we behave. Actually, what's taking place is the brain is listening out to the sensory experiences to how the body is feeling. So if the body starts to feel unsafe, so if you get like butterflies in your stomach, if you your heart starts to beat faster, you get sweaty palms, etc., the brain is picking up on those feelings, and therefore it flicks the brain into safety survival mode. And what happens then is the thinking brain gets flicked offline. And therefore, when somebody's in this safety survival mode, the things like reasoning, perspective taking, so all that really high functioning thinking that takes place isn't able to happen. So just want you to bear this in mind, because actually this will affect the work and your engagement with adults that you're working with. Because if they're getting constantly flicked into safety survival mode because of the way their body is feeling, so even though they may no longer be living with the adult that harms, the reality is the body is still having those experiences. So you might cognitively think, well, actually, they're no longer in that relationship or they don't have contact, but actually the body has recorded that, and the body keeps remembering, and therefore it's picking up all the time, and it's probably hyper vigilant to warn that person and to keep them safe that there's perceived threat. And remember, it's perceived, so we're not actually saying there is threat, but even when they meet you, you have conversations with them. It might be certain times of the day. There's going to be triggers as well that you need to be aware of. The other thing to remember as well is research does demonstrate that a high number of victims of domestic abuse are likely to have experienced domestic abuse when they were growing up as well. So they've lived in a household where whereby they were subjected to abuse, and that's from whether that it was back a while ago, children were seen to be witnesses of domestic abuse. And people felt that, well, actually, the child wasn't around, or they was asleep when incidents was taking place. What we know now is actually the biggest victims of domestic abuse are the youngest victims, and therefore it's not for you to be mindful of babies as well, and the impact domestic abuse will have on babies. But when you're working with the adult victim of domestic abuse, they may have had previous experiences as well, and they might have minimized it. They generally might have not known. They probably thought that was the norm in terms of, because that's what they grew up around, and therefore they might be confused as to why you're offering therapeutic interventions that are looking around their regulation. So you might be thinking, okay, this is great because it's going to help you. It's going to help you and your child. But the actual victim themselves actually might not be up for the work that you're thinking about because of their own experiences that they went through in childhood. So you've also got to think about those experiences that they've been exposed to and the impact of their early childhood experiences will have on their current help-seeking experience. Now, a positive help-seeking experience from yourself makes a significant impact and a long-term impact to how they engage with other services or how they seek help in the future again. So as a child, if they'd experienced domestic abuse and now they're an adult that's a victim of domestic abuse, if they didn't get the help or the support that they needed back then, it might be that they're reluctant to get the help now. Also, it might be that they've got some particular views about what's going to happen to them or to them and their children if they disclose or work with you. So towards the end of this presentation, we're going to look at you as a practitioner and actually what you can do to hold this safe space for them to be a safe, grounded adult so you can engage in this co-regulating experience. Now, when we talk about co-regulation, a lot of the time, us as adults, as the professionals, we kind of think that, well, actually, we need to get this adult to be able to self-regulate. They cannot rely on you as a professional. But actually, what we know is you can't self-regulate if you've not had the experience of co-regulation. And a lot of the individuals that you'll work with, a lot of the vulnerable people that you'll see and work with have not had co-regulating experiences. Therefore, don't come from a place of trying to get people to self-regulate. You should come from a place of actually providing a positive co-regulating experience with them. Now, this comes up quite typically, and it's around mental ill health and the impact of domestic abuse. And as clinicians, as frontline practitioners, as people working in the education sector, even the police sector, what we start to do is start to diagnose individuals, or themselves start to Google search or kind of want answers as to why they're feeling this way. So typically what we see is adults and also children and young people seeking diagnosis, or they are diagnosed. And one thing to think about is the impact of trauma that has on their body and how it can present. And typically the trauma, the PTSD, post-traumatic stress disorder symptoms, can come across as whether that individual is depressed, whether they've got an anxiety disorder. You also typically see women diagnosed with emotionally unstable personality disorder or borderline personality disorder. And also what you start to see as well, particularly in children, for example, is diagnosis as looking into autism and ADHD. So it's very careful for you to do. So it requires quite an in-depth clinical assessment, but also from your point of view, that you're looking at the symptoms that they're experiencing from a neuroscience and a trauma-informed lens. Because what you don't want to do is start to label people, or say people have got depression, for example, or anxiety, and not consider the impact of the trauma that they've been experienced. So it might have been years that they've been subjected to domestic abuse. They found ways, in terms of their body, have found ways to be able to cope with that trauma. And how people present can also be different in different situations. So what happens is, for example, if you're working with an adult and you're doing some type of intervention with them, or you're doing an initial assessment, if their body's gone into safety survival mode, what happens is they struggle to think quite clearly. Also physically, their body can become quite floppy. And what happens, why that happens physically, is that the body starts to prepare for what might come. So if they've been exposed to physical abuse and violence, then the body can come quite limp, unable to be able to prepare for what's to come. That can happen in your sessions, and you might not be aware that that individual is going through this, that experience, that physical experience whereby their thinking brain is offline, so they can't quite think clearly. So the things that they're telling you is probably either rehearsed answers or information that you want to hear, as opposed to information that they want to share. And also, if they're thinking about, for example, police intervention or a quick assessment, what we know actually is that that's a very short window for them to be able to resource and communicate to their brain that actually know they are safe and they're feeling okay, that their thinking brain comes back online again. So how it can present is actually that somebody maybe even they come across of maybe having a learning difficulty, or that they're depressed and really low in mood. But actually what is happening is the physical response has kicked in, and therefore they can't verbalise actually what they do want to say. They just get flicked into safety survival mode. What also can happen with adults' mental health and well-being as well is they might start to engage in substance abuse. So you start to maybe see addictions whereby they're trying to find coping strategies to cope with the emotional pain and the trauma that they've experienced. And this might through from smoking, so chain smoking, it might be alcohol, it might be illicit substances. But it's really looking past the behaviour of abusing that substance and thinking about, okay, what function is it serving? We know it serves a function because people use it, because it's like a sticky plaster. It does help. It gives them some sense of relief. It might help them to cope with the emotional pain that they're feeling. It might help, or people describe it as helping to calm their nerves. So that constant fear of either feeling sick, feeling anxious, feeling on edge. And if you've met somebody that actually is in this process where they're absolutely riddled by this emotional trauma that they're experiencing and emotional distress, it actually comes across, and when you look at them physically, that they actually look like they've been abusing substances for a long time. But actually, that's not the case. You also might start to see eating disorders or disordered eating. And it's important to recognise the difference. Eating disorders, you're looking at a clinical diagnosis, whether it's anorexia, bulimia, where disordered eating might be that it's not into full-scale disorder, but their eating habits have changed. And what we can see with adults is that the one thing that they can control or feel like they're in control of is what they eat. But also what may have happened in this process is that appetite may have been suppressed. And that might be due to the nervous system in this safety survival mode. And also then that also impacts on the gut health as well. So they're no longer been able to attune to those feelings in their body. So there's this dissociation that's taken place because of the abuse that they've experienced. So when you're asking questions and thinking about things, or even asking them to engage in exercises, so whether it's things like mindfulness, that's become quite popular, you need to really think about actually, is it safe for somebody to engage in these interventions? Because they might struggle to actually reconnect with their body, reconnect with those feelings because of the traumas that they've experienced. So you have to look at things from a different lens and ask people to opt in. It's really important that when you're having conversations that we talk about opting in, and that opting in allows people to help them to create that safe space and feel safe, that they can have a try, but also know that they're not pressured to engage in this. Now, self-harm and suicide. So again, self-harm is not a mental illness. It is a behaviour and it's a coping strategy. And if you see your colleagues referring to this as that they're attention seeking, what I really want you to do is change the language to something like, okay, this person is connection seeking or they're help seeking. When you change the language, people think about these people very differently. They actually start to put it into perspective that this person must be going through a lot of emotional distress and trying to find ways to cope with that emotional pain. And there's different forms of self-harm, and each form of self-harm has a different function. So don't assume that if somebody, for example, is cutting, that it serves the same purpose for somebody else that you know that may be engaging in cutting. So it's important to find out for that person, what is that function, and not have these contracts in place or asking this person just to stop self-harming. It's the same with substance abuse. They can't just stop. We need to give them other healthy coping strategies that can support them to replace these maladaptive coping strategies. So the other thing for you to think about is then things like autism and ADHD. So neurodiversity and the impact of trauma can have. So that's whether that's children and adults. You typically might see that females are diagnosed later on with autism, but really looking at it from the impact of trauma. And if you look at the research, there's a real overlap between the symptoms or the kind of early warning signs that you might see in autism, for example, the eye contact, or it might be difficulty with communicating and engaging and building relationships with other people, or this black and white type thinking. But actually, if you think about it from a trauma-informed perspective, people and adults have had to learn not to look at people in the eyes because of fear of the abuser, what they might start to say. So actually, it might be that they become triggered, or it feels uncomfortable for them because they're experiencing the trauma. So just want you to spend some time to think about that. Are we doing questions at the end, or do you want me to take any of the questions? I can't see any of the questions. So can one of the co-presenters let me know if there's any questions that you want me to answer at this point?
We haven't got any questions at the moment, Dr. Patel. But if people can use the Q&A bar that would be really helpful, so we can prompt Dr. Patel if there are any questions.
Perfect, thank you. So I'll move on. So when somebody's feeling unsafe, and feeling unsafe will happen whilst they're in the abusive relationship, but also life after. And when we say life after, if the adult is still having to have contact with the adult that harms, whether that's because of child contact arrangements, life actually still feels unsafe for them. And external signs of safety isn't enough. So whether they're in refuge, whether physical safety things have been put into place, whether that's doorbells or alarms, or whether the police are involved, or whether there's certain orders in place to prevent the adult that harms getting in contact with them, the adult as well still might feel frustrated, and therefore this could impact as well their engagement with their children. And trust is hard, so trusting people is really hard. And also this applies to foster carers and kinship carers as well. So it may be that there's additional stresses that are there. The body's also processing that they're in a different situation. And this different situation will also feel unsafe because it's not what people are used to. So we typically think that they're out of an abusive relationship. They're in this safe space in terms of physically in this new home. But actually, because it feels so unpredictable and there's uncertainty, the body is picking up on that. And you've probably seen that in the relationships that you have with the people that you work with. It might be that you're just forming a really good therapeutic relationship with somebody and they start to withdraw, they start to maybe not attend. You might think that some unconscious sabotaging is going on. But actually, that is quite natural to do. If somebody's not had this experience of actually feeling safe or being with people that help them feel safe, the go-to response is to reject that or kind of move themselves away from that. Because actually, if they've had abandonment difficulties before, particularly with children, and adults in their childhood, then actually the kind of logical thing to do is for you to withdraw first as them as the adult. So actually they're in the position of abandoning you, rejecting you as the professional. So they're not going through that emotional heartache, that emotional trauma of another individual that's leaving them. And that becomes quite hard for you as a frontline practitioner, that you're putting in this work, you're offering sessions, people may not be attending, and then you're kind of left with what do I do? And this is about how you can be creative and let people know that you are still there for them, that regardless if they don't turn up, that either you can send an appointment, it might be through therapeutic letter writing, just to let them know that you're still there, and should they want to reconnect with you, that they can. In that therapeutic letter, you might summarise some of the work that you've been doing with them, so they always have it with them. Remember, it's giving them that positive help-seeking experience. And we know the impact of trauma has on people's physical and mental health. And just by you being that one adult that provides that therapeutic space, that safe therapeutic space for an individual, that provides that co-regulating opportunity, you can significantly decrease the risks associated with this person going on to experience further mental health difficulties, but also physical health difficulties. And that's whether it's cardiovascular diseases, skin difficulties such as eczema, but also like things like irritable bowel syndrome. Now, the other thing is about this numbing, and constant movement feels essential. So when you're working with these adults, it's important that you think about your physical environment that you're in and how they're presenting. So it might be that they present as quite quiet, quite shut down, or they're quite energetic on the move. You might see that they're bouncing in terms of their legs moving up and down. They're unable to sit still. You might see that they're pacing. So again, it can present like it's looking like whether it's an anxiety disorder or ADHD, for example. But it's really thinking about it from, okay, what is this person experiencing? What has their body experienced? And therefore, what physical stuff is going through that individual for them to present in this way. Concentration is really difficult. So thinking about the times, the length of your sessions, and thinking about what you're trying to cram in these sessions. So if you go with this agenda that you've got to do X, Y, and Z, and you're just focused on that and not focused on being in the room with this individual, they're not going to be able to engage with you. They're not going to be able to connect with you. They're going to be thinking about other things. It might be even that they struggle to think about what you've been saying to them and retain that information. So don't be surprised if you kind of go back for another session and they're asking you very similar questions, or it feels like you're introducing new information even though you've previously said that before. So professional interventions can also mean that there's no privacy. So visits from professionals at home can be quite exhausting. And this is something where we think about systemic practice and how do we start to move to trauma-informed ways of working, that every time a professional goes and engages with this individual, they're not constantly reminded that they're a victim of domestic abuse, and they're not getting re-triggered and re-traumatized. And really think about your own practices. So when you engage with a new person that you work with, in your assessment process, are you asking them to retell you their experiences of domestic abuse? And if you are thinking about the impact that has, that they're reliving and having to retell that story, we leave and go on to our next appointment, but that can impact that individual for days and weeks after you've left, because they've had to retell their story, they're reliving the moments that they've been experienced by abuse. It's also another person that knows about their past, so in terms of their own feelings, in terms of confidentiality, more people knowing about what they've experienced. There's also lots of other emotions that are surrounded with this. So there's guilt, there'll be shame, there'll be anger. So there's not just one emotion that's holding this around this individual, and they'll fluctuate in and out of feeling different emotions. They might even miss the adult that harms. And that's okay, but they need to feel safe to be able to verbalise that. Sometimes as well, that child and parent are having to participate in interventions that are typically driven by tick box exercises, or whether it's court proceedings. So things like, for example, CAFCAS. It might be that the safe parent is getting dragged through court proceedings. It might be that court proceedings is another way to abuse the safe parent, for example, or to abuse the adult, even when it's financial court proceedings. And thinking about the involvement that has on children as well, and the impact it has on their child. So if CAFCAS have been asked to do a recommendation, so whether it's section 7, for example, that the child is interviewed, they're asked to talk about whether they want contact with their other parent, the impact it's had on them, how they are at school and how they're feeling. And remember, this is all with somebody that they've never met before, which is really unusual. There's no other social situation whereby we have to have these really deep conversations all about our trauma and things that we've experienced with somebody else. If you think about it in your own lives, the probably only people that you talk to about your own traumas or things that you find difficult is probably close friends or family members, but you are choosing who those people are. In this situation, they don't get a choice. They don't know who's going to be referred, who's been assigned to them. They don't have, in some cases, an option to opt out. And if they do, then they know how negatively that looks on them as well. And the fear of whether it's losing their own children, or the fear of not feeling safe, that they need these systems around them. Also, the coordinating of appointments, typically at certain periods of somebody's journey, particularly if they are about to leave or have left, which we know is a significant risky period. It's a real risk point. That's a lot of professionals that do get involved. but they are left to coordinate appointments, trying to manage all these different services. And I know as professionals ourselves, we don't even know how all the services work together or who to contact in certain situations. So imagine being somebody that's experienced domestic abuse, going through the trauma that they are experiencing, and having to coordinate these referrals, these appointments, and actually typically they don't know what the referrals may for. So we've come across a lot of individuals whereby services providers have contacted them to say, hey, we've been passed on your details, we are the mental health service, and you've been referred to us. They've not opted in terms of, and then that leaves them to thinking, okay, that person that I met last time, did they think that I've got some mental illness or mental health problems going on? Because why have I been referred to this person? And typically it's because of the way that our triaging system works or our front door contact works, that kind of, we're not thinking about the victim in all of this. Also then we've also got to think about education as well. So the impact if your individual, the adult that you're working with, are also getting pressure from education. So if their child is not attending school, or if the child is presenting with behaviours that challenge, that also starts to increase that pressure. Not all schools look at things from a trauma-informed perspective, so they may be putting in consequences and reward systems in place, and therefore their child is experiencing punitive approaches. Might be as well that the safe adult feels they're to blame, or they feel like professionals are looking down on them because they can't get their child into school. So just because professionals are involved, it doesn't mean that it's a pleasant experience for people as well. Any questions at this point for me to pick up on?
I think we've got one question, Dr. Patel, from Nathan, who's asked, can a victim become an abuser as well? And if any referencing with your answer could be provided.
Yep, so research does demonstrate that there's a high probability that a victim of domestic abuse can become onto an individual that harms. However, that doesn't necessarily mean that that has to be where that victim goes to. So if we put in interventions in place, if we support that victim, then most definitely the trajectory doesn't have to be that they become somebody that becomes an individual that harms. And you might notice with the language that I'm using that I'm not using the words like perpetrator, because actually if we're thinking about trauma-informed perspective and we're thinking about, okay, how can we reduce domestic abuse? How can we work with the adult that harms as well as the victim of domestic abuse? Then we have to move away and change language as well that we're using. So yes, research does demonstrate that. Research also does demonstrate that if children are exposed and victims of domestic abuse, it increases their likelihood as well to become victims of domestic abuse.
Can't see any other questions at the moment. We've just had a comment which is from David, who's just said that typically in his organisation, the common response from a mental health colleague is often the behaviour is an expression of their autism and not a mental health issue. And trauma-informed practice gives a much more holistic approach. So, some praise there for you, Dr. Patel, on the presentation. So, so thank you, David, for your comment.
Yeah, David, thanks for that. And actually, I come across that quite a lot as well, where my question back is, does it matter? We're not trying to say, okay, this is autism or this is mental ill health. Actually, what we're trying to work with, regardless of whether we think it's autism or mental ill health, you're treating the symptoms that are presenting and how somebody is presenting in front of you. And does it matter where it comes from? No, it doesn't. It's still anxiety at the end of the day. And whether it's because of that individual's got a diagnosis of autism, they're still experiencing anxiety. So any kind of support that you're kind of looking for, particularly with mental health services, is really focusing on how that individual's presenting and the impact it's having on their life. So it becomes a disorder if you think about it as a continuum. So we all sometimes wake up and we feel quite low in mood. That's the reality. You can't be happy all of the time. And it's unrealistic to think that you're going to be happy all the time. So you might wake up, you think, oh, do you know what, I can't be bothered to go to work today. And in your head, you're thinking about all the reasons of kind of how to throw a sickie or why you shouldn't go into work today. But you kind of get yourself out of bed, and as the day progresses, your mood starts to lift. There might be times as well that you're quite irritable, you're frustrated, you're annoyed with it. It might be relationships at home. So you start to like maybe slam the doors or the kitchen cupboards, kind of get a banging. But that is our natural kind of emotional state. So we'll fluctuate. And then there might be times where actually people have significant event in their life. So it might be you've had a bereavement, there might be something stressful going on at home. So at the moment, there might be the cost of living crisis and the financial stress. And therefore, your change in mood might go on for a longer period of time. So you might start to see that you start to neglect yourself, you might not start to eat properly, you might start to be drinking a little bit more than usual in terms of alcohol becomes a regular thing and an evening. But nevertheless, you're still able to function, you're still able to go to work, you're still able to hold relationships. And then what can happen is then your mental health starts to deteriorate even further, where you start to maybe go into early signs of it becoming a disorder. So whether it starts to go into depression or an anxiety disorder or an eating disorder, and that's at the point that you might start to really seek professional help or early intervention. And then you've got the other end of the spectrum where in the fourth quadrant, it's thinking about those that actually maybe need hospitalisation, but then also you've got those that have had hospitalisation maybe or care in the community, and they've had treatment, now able to live a life that they're living with their mental health difficulties. So we think about anxiety in that way. Does it matter if an individual's got a diagnosis of autism? No, it's just how you're going to work with that individual to support their anxiety is going to be a little bit different to meet their needs that they have. So the other thing for you to think about is when you're working with individuals is what biases are you holding and kind of what expectations are you holding? So typically what we see in education settings and even in adult settings is everybody's got to be happy all the time. And it's really unrealistic. We see a lot of signs around happiness and be happy. We've got smiley faces everywhere. But if we're trying to get people to a place of happiness all the time, we're actually setting them up to fail, because that's not life, that's not possible. And actually those other emotions are there and they're hardwired into us for a reason, to keep us safe. So biologically, even if you go back into caveman days type thing, they're there for a reason. The same with anger. So if you go in working with these adults that have experienced trauma like domestic abuse and trying to repress feelings like anger and sadness, actually what you're doing is you're not allowing them to experience and process that trauma. And then all that happens is it manifests in the body and they become physically unwell. So trauma-informed practice, what does this mean? These are some of the principles. You can have a look at the working definition of trauma-informed practice in this source that's on there. But actually how I describe it and how the simplest way to look at it is a way of being. This is not something that you do to somebody in an intervention or in one of your sessions and then you switch it off and go to your next one. This is a way of being. And actually, if you get to this point, it's quite frustrating, because you'll be on holiday and you'll see an adult, the way that they're talking and interacting with each other, or the way they're interacting with their child. They might be dragging them out of the pool and saying, you're not going into the pool the next day, etc. But you start to see things from a different lens altogether. And actually what it is around every interaction and every connection you have with somebody, you're thinking about their safety. You're thinking about how can you be that safe, grounded adult that provides that safety, that space for them to be able to feel safe. You're also thinking about how you're not re-traumatizing them. So you're preventing re-traumatization. You're not asking and digging into their details. And typically we do that because us as adults are quite nosy about it. We're quite intrigued. For some reason, we're quite drawn into these conversations where it's all about trauma and hearing things like that. Also, trauma-informed practices around choice and collaboration, working together, taking things, so you're seeing things as a buffet. Hey, these are the options that I've got. Take what you want. So you have a tool, you have a resource full of toolbox, like tools that you have for people to dip into. Some people might not be ready for what you feel they're ready for, but you're open and feeling that actually that's okay. You're also mindful around cultural aspects as well. So I'm from an Asian family, therefore things around talking about domestic abuse or mental ill health is actually quite, it's not really done in our culture, seen as you kind of just pick yourself up and get on with it, or actually that's the way it is. Or there might be other cultural considerations that you need to take into consideration, that other stresses that might be going on, or other cultural practices that is actually re-traumatizing them and traumatizing them through this process of domestic abuse that they're experiencing. Now, for you to be trauma-informed, you have to be able to ground yourself and notice your own energy. You can't be thinking that you're just switched off and, you know what, I come to work to do what I do, I go home, I leave my home stuff at home and I leave my work after 5 o'clock when I finished. As much as you might think that's true, it's not possible, because it stays with you, whether it's in your mind, whether it's in your body, you're thinking about things, you're thinking about the stress. So you need to notice how you're feeling and the energy that you're portraying. You all will work with somebody, and I call them people like radiators on steroids with jazz hands. So if you're not a morning person, these are the people you don't like to be around. These are the people that are really excitable, really chirpy, really kind of overly happy all the time. But actually that energy is not helpful either. That can increase people's anxieties. It can make you feel quite stressed out. I'm sure you've all sat next to somebody that's quite an anxious person and you start to feel anxious. So people pick up on each other's energy. So you need to be aware of your own. You need to be present with the now. If you're working with adults and if you're working with children, particularly children as well, children are like dogs. They sniff out when you're being fake, if you're trying to hide something. So if you're not focused in the present moment, you're thinking about something else, that's going to change how you present. You've also got to be okay with repetition. What we know with people that have experienced domestic abuse, that impacts how they process information. It impacts how they retain information. So it's us as adults, as the professionals that feel like, oh, why am I repeating myself, or they're going to get bored of this. Actually, adults and children really prefer that you do repeat information and you keep information as simple as possible, not lengthy information or text messages or emails or any information that you're presenting. Really simple, really easy. You're not you're not kind of making them feel inferior or kind of anything like that. You're actually responding to their needs. You also be able to notice when you're feeling triggered. So there's going to be certain people that you meet that you dislike, that bore you, that irritate you, frustrate you. You might actually really overly like somebody and feel that you want to go above and beyond like anybody else that you'd work with. You need to be able to be self-aware. And actually, all these things are quite difficult to do if you're not a naturally self-aware person. And also, don't forget that you may have experienced your own trauma as well. And within our sector, it typically attracts people that have either got a personal experience of mental health difficulties or some form of trauma, or you know somebody that's quite personal to you, and that's made you want to come into this sector and work with people. It's not an easy job to do. It has a massive impact on your own mental health and well-being as well. So think about people as like meerkats. They're looking out and sensing for danger all the time. So how calm and how regulated and safe your energy feels is going to be the critical point. You are the key resource. There's no magic wand, there's no amazing intervention. Even if you look at the research, whether it's CBT-based intervention or program, a structured therapeutic program, it's actually the relationship with the individual. And you'll always see on feedback, when you ask for people to feedback on interventions, they feedback on the person that facilitated it. So actually stop looking elsewhere for this magic wand, and that magic wand is you. You have the ability to be able to make and provide this safe space for adults to be able to access the help that they need. I'm sure you can all think about somebody that's helped you on your journey, whether it's through school. You can all think about a teacher that actually you liked and you disliked. And it's not because of the lessons that they taught, it's how they was with you, their way of being. So always remember this and think about the nervous system and how people are responding. There's typically people that people gravitate to in your service, and everybody wants to be around that person. You know, in school settings, it's typically where all the children are referred to. For example, go and see so-and-so, they'll help you, or it's where the children gravitate to. They're not a fairy godmother, they don't have a magic wand. What they have is this ability to be able to create this safe, regulated, calm environment. The energy that they're giving off helps people to feel that they want to connect with. So one thing for you to think about is how attuned are you to your own emotional energy? And we all quickly exchange that energy. So how much are you aware of how you're presenting, how you're coming across? And your emotional energy will change as well. We all know this is a particular difficult time of the year. Why? It's long, it's dark nights. There's a build-up in terms of coming up to Christmas, for example, but also our last break might have been the summer break. So everybody's emotional energy at this point is quite depleted. Also, we might be working in systems that we're quite frustrated in. So we might feel that we're working a broken system. We might feel that we're constantly apologising on behalf of the system. It might mean that, you know what, I want to do more, but I can't. And that all has an impact on your emotional energy. So you being able to be attuned to your emotional energy gives you that indicator to say, do you know what, before I go into my next session, I need to take some deep breaths. And the reason why we say take deep breaths is, one, because you always have it with you because we're alive. And two, what happens is sending the oxygen down into your body. So when we say deep breath, you're trying to get that oxygen through into your body and down as far as you can go. So it'll help to regulate the nervous system, the vagal nerve that's taking place, which in turn will help to regulate you. It'll make sure that all the parts of your brain are working together. So if you've seen Dr. Dan Siegel's hand-brain model, flipping the lid, then that's a great way to make sure that all your three parts of your brain are working together. Now, the other thing for you to think about is your physical space that you're in. So we're trying to reduce re-traumatizing people, and we're only trying to reduce it. You're never going to know everybody's triggers. So we're trying to minimize it. So really think about the colors that you wear. Also, if you're using like things like aftershave or perfume, etc., those might be triggering smells for people that have experienced trauma. But also think about seating. So I know if we all was sat in a conference right now and I asked you to leave the room and then come back in, you're all going to go back to the same seat that you were sat in. And if one person moves into a different seat, it creates a whole kind of discomfort. So really thinking about seating as well. Where do they feel comfortable to sit? It's not always easy to access the same location in terms of the same room. But if things have moved or things have moved in the room because somebody else has been in there, acknowledge that that room has been changed. If you're working in an education environment, for example, if you're working maybe in a family hub and you've got a physical space and you're decorating it, please don't be don't try and go to decorating it with lots of vibrant colours, lots of posters, lots of information everywhere. For some reason, we like to plaster a lot of information around people. We like to create fancy text. We like to put all these images on the walls and notice boards up. That can be really overstimulating for people, particularly people that have experienced trauma. And therefore, if you have to have information up in the rooms, keep it at the side or of the back of them. And then also keep it very neutral and soft colours. So use pastel colours. And that might be, if you still want your two-tone borders, then maybe having white backing paper and a light blue border. So really just being mindful of that, stepping into your own environment and just thinking, actually, we don't decorate our house like that. So why are we decorating these spaces where we're seeing people therapeutically and trying to create this warm, safe space for them? Why are we decorating it in this way that feels quite overwhelming? We've got a hand up. I'm guessing that's for now, so I'll just pause while we respond to that. Do you want to unmute yourself, or I'm not sure if you can unmute yourself?
We haven't got access for our attendees for mics and cameras, Dr. Patel.
Okay.
But if you want to pop it in the Q&A bar, whoever had their hand up.
So also,
there's a
go for it.
Sorry, Dr. Patel. There's a question in the chat bar about a high number of our domestic homicide reviews. This is from Tara Jones. A recurring theme is of victims who have suffered multiple traumas over their entire lifetime, and services really struggle to support in a joined up way. For example, a victim of childhood sexual abuse, raped as a teenager, multiple abusive relationships. Many of our services have very specific referral criteria, which reinforces the issues you've already raised. How do we address this?
So this is where the systemic changes need to take place. So if, for example, if Surrey is identifying that this is a service problem because of the referral criteria, or as organisation because they have to meet a certain criteria before they can access help, how can we change this at a systemic level? So then those people that we actually know are more high risk or likely to go on to experience even more significant kind of trauma or result in the reviews that you're seeing, that actually then we've identified from a systemic point of view that this system isn't working, or it's broken in this part, or it's not creating equal access, because we're trying to create a blanket approach which doesn't meet the needs of these individuals that we're talking about. So if there's anybody strategic, typically this time of the year is where people are reviewing, looking at commissioning, whether you've got a trauma-informed. I know actually in your service you do have a trauma-informed lead. So how can you bring in these individuals and raise these concerns with them to say, actually, let's change the system? Because at the moment, what's happening is even when you have to do your assessments and you're re-asking people to tell their stories, it's because you're not sharing information, or you can't share because of the systems don't allow you to share information. So at the end of the day, adults and children are picking up the slack of kind of us as a failing system, not being able to get this information. Okay, so the other thing for you to think about as well is access to toilets. So you might think that an individual is trying to get out of your session, or they're trying to get out of the classroom if you're working with children. But actually, the impact of trauma has a significant impact on your gut health as well. So typically, they do need to go to the toilet more often as well. So just letting them know where toilets are and how they can access them will make a significant impact to people. So your beliefs about the person that you're working with, about the adult. So sometimes you think you know the person that you're working with, so you've made these hypotheses or these conclusions, firm conclusions. Either you've worked with them before, or you've read about them, or it might be that they're kind of a revolving door individual that you're working with, that they keep coming in and out of your service. or that you've heard other people talking about them. All these things that you pick up on and the information and the beliefs that you have will impact the work that you do with them. So if you believe, actually, what's the point of working with this individual? They're not going to get anything out of it, or this child's not going to engage, or do you know what, this family, there's more kind of, it's a generation problem here, and there's nothing that we can do. Well, guess what? You're not going to be able to shift that, and they're probably not going to make any progress either. So your beliefs about, actually, do you know what, they can do this, and you're believing in that individual, that you need to be able to acknowledge your beliefs that you might have, even if they are those negative ones. And to serve them fully, you have to upgrade what you choose to believe. And you're learning about the person that's in front of you. You're not making any judgments. If you are making some hypotheses, you make sure that they are hypotheses and they're not firm conclusions. And they always say don't fall in love with the hypotheses, because it means that actually you can start getting other information that they're giving you, or you're getting from other assessment information, and piecing that together to be able to support this individual. Now we're going to finish off with thinking about vicarious trauma. And I always finish with this, or start with this, because actually the work that you do will have an impact on your mental health and well-being. And that's a reality, and it's the cost of caring. Because you have empathic relationships with people that you work with, you see, you hear very difficult information. The information that you're exposed to, it's even your wider colleagues, whether it's administrators, for example, they're seeing information and hearing information that is distressing. Because you have empathic relationships and not sympathetic relationships. And what I mean by that is sympathy. If you describe it to another team member, sympathy is kind of looking over a cliff edge, seeing somebody's down there and thinking, do you know what, it's a bit crap down there, isn't it? You've acknowledged somebody's down there, they're not in a great position. Empathy is you joining that individual and being with them. So you might not physically join them, but you're trying to put yourselves in their perspective, you're trying to emotionally be with them in their moment. And because you're doing that, indirectly, you will be exposed to trauma. And if you don't process that trauma, if you don't have the ability to process it or think about your own self-care, and what happens is it manifests in your body. And these symptoms actually look like PTSD. I'm not saying you've all got PTSD, but what I'm saying is symptoms are linked closely to PTSD. And how that looks like is when you take annual leave, first 2 or 3 days you're unwell, you've got aches and colds, unexplained aches and colds, you're feeling unwell, and then you start to recover towards the end of your annual leave. That's because the trauma is getting processed, because you're finally resting, your body's able to rest. And if you don't rest, what happens is your body makes you rest, because it starts to shut down and you become physically unwell. You also, for example, might get skin conditions, you might get irritable bowel syndrome, you might start to experience unexplained aches and pains during your work. And that's because you are not having the opportunity to process the trauma. So there's clinical supervision. That's a great way for you to process trauma. So it's not line management supervision. It can be delivered on a one-to-one or group basis. And this gives you this opportunity to reflect about the work that you're doing, the impact it's having on your mental health and well-being, but also to think about things. So from a risk management point of view, it might be that you're feeling unsure if you're able to manage this risk. Might be certain triggers or a certain case that you want to reflect on. But also, as you're doing that, you're developing your psychological mindedness. So you're able to start to think about and process information quite differently. It doesn't become so personal. It becomes psychological mindedness, that you're looking at it from another lens. Now, a good supervisor has experience within the sector that you're working with, but also a good knowledge base on mental ill health. So whether we use psychologists at Innovating Minds to provide supervision. Also, the frequency can be varied. On average, it's about every 4 to 6 weeks. And if you're having group supervision, make sure your manager's not in that session. There's no way you can create this safe space and say what you really want to say if your manager's in your session. And also managers need their own space because they've got other things that they want to be reflecting and talking about that's not appropriate for their team members to be talking about. It's very evidence-based as well, so it's introducing you to new psychological models, new different ways of thinking, so you can think about things from an alternative perspective. So we'll open it up to any questions, but if there is anything that you want to find out more, I hang around typically on LinkedIn, so if you're interested in more content, then LinkedIn is the place to find out more, but there's also free webinars as well on our websites.
Okay, so we've got a comment from Shatal who said, "Hi, Dr. Patel. Thanks for your presentation. My struggles as a practitioner has been to find counselling support for people who have experienced abuse and face complex PTSD." Not sure if there's anything you want to come back on that.
One thing is, are they wanting counselling support? So sometimes it can actually be counselling might mean that they have to relive and go through their trauma that they've been experiencing. And for somebody to be able to do that, they need to be in a really good place, emotionally able to cope with this aftermath of the session that they're having. So I think it's important that don't assume that counselling is kind of the only intervention that they need, and that's going to be the only thing that they can get access to. So if there are alternatives, so if you can't get access to counselling, but you've had a conversation to say, and you've set it up to say, actually, do you know what, counselling looks like this, you're going to probably have to talk about what you've experienced. Sometimes as well, it's going into their childhood trauma as well, and thinking about things in the past. So making sure that individual knows why they get, like, what the counselling experience is before you want to put in the referral. If you can't get access to counselling, then also look at other forms of therapeutic interventions as well. I don't know specifically in Surrey. I know there's certain domestic abuse organisations that do have access, but also there's the Healing Together programme as well, which some of the domestic abuse services are set up for, and that's a bodily based approach, trauma-informed approach, and that's 6 sessions, and people are asked to talk about their trauma.
Thank you. And I think there's just a question about the link to the website. I can put that in the chat, not a problem. Are there any other questions?
I'll just put in the link, because there's a couple of websites that have different stuff on there. Perfect, thank you.
Just a comment from Gillian, just asking if there's any guidance about how to support staff who are really concerned about learning about this way of working. And are there any models that have worked with this methodical approach, I guess, to trauma-informed practice?
Yeah, so we in Surrey actually we're delivering trauma-informed training. So it's 2 days of trauma-informed training, and then you go into specialised areas. So whether it's domestic abuse, anger, feelings, anxiety from a trauma-informed perspective, but then also you become an accredited facilitator to deliver the Healing Together programme, so you can deliver these interventions direct, which means that you're implementing trauma-informed practice with the people that you're working with. So there's training out there, and I'll send you the link as well. So if there's any, because we do have sort of subsidised places in Surrey for the Healing Together training and the trauma-informed training as well. So I'll make sure that I post that as well in there.
Thank you. And I think we've got time for one more question. So this is from Claire. Claire has asked, if someone is showing physical manifestations of their trauma and you recognise specific things within their history, what is the best question to ask in relation to whether they are ready to address this?
So you're asking about their body, how their body is feeling. So you're not asking about the abuse that they've maybe experienced late in childhood or before or in their adulthood. You're getting them to ask about, okay, how's your body feeling? And they might say either I don't know or I've not paid attention to it. And if that's the case, ask them to go slowly and do things comfortably. So it might be that at the start of your session, you're using grounding exercises, and that's to help to bring that person into the room. So it might be stretching exercises. So kind of even just putting your hands up in the air or reaching for the sky and kind of stretching out your body. It might be progressive muscle relaxation where you're clenching and letting go. So your fists, you can also do that while they're sat down. So people don't even know that that's taking place. So really starting in terms of, okay, how's your body feeling? And what does that feel like? Or even can you label the emotion that you're feeling? How does it feel? And don't assume because somebody's saying, well, that's making me feel sad, that you know what sadness feels like. Because how I feel sad would be very different to how you feel sad. So getting them to try and describe that feeling. Don't be tempted to go down the rabbit hole and be like, okay, what happened? When's the last time you felt like that? Was when you was experiencing abuse or something like that? You stay away from those questions because they need to feel safe and have that regulated safety in their body first.
Thank you. If there's no other questions, I'd just like to thank Dr. Patel again for your time. I really appreciate that session. I think it's really, really important that we highlight these topics, although they're very sensitive. It's important that we kind of address them in a way we can help people who may have experienced it. So thank you. I really like the meerkat analogy. So
Really, yeah, we didn't get a chance to do the hand brain model, but definitely look out, Google Dr. Dan Siegel's hand brain model. There's another analogy that's really amazing to use with adults and children as well.
Thank you. And Dr. Patel will share some of the links in the Q&A bar, so please look out for those.